morning, everyone. Morning, Happy New Year. We're glad to be back. Welcome to the Healthcare and Wellbeing Overview and Scrutiny Committee. It's the 7th of January. I don't think we've got any plans for any alarms going off, but you know the drill, I think. Those are the Fidos over there. Do we have any declarations of interest, please? Councillor Boynton.
It's just my usual non-pecuniary employed by health service.
Thank you. Councillor Owen.
And likewise, Chair, as usual, just health and wellbeing board, the ICB and the ICP membership.
Thank you. Anyone else? No. I'm just a member of the Bridlington Health Forum.
In that case, Chair, I should declare a non-pecuniary interest in them and also a trustee of Bridlington Health Forum.
Thank you. So regarding the minutes of the last meeting, which was on the 3rd of December, could we have a proposer, please? Thank you, Andy. And a seconder. Thank you, Councillor Stewart. Okay, so our first item today is the podiatry consultation. I'm not sure who is leading on this one. Would you? Thank you. Joanne, would you like to introduce us? Thank you.
I will. Thank you very much. I'm Joanne Evans, and I'm the Assistant Director of Community Integration working as part of the ICB, and my role is commissioning services. And I'm here today with my colleagues from City Healthcare Partnership, who I'll let introduce themselves.
Hi, good morning. My name is Marie Serajudi. I'm a head of service at CHCP, looking after therapies and rehab services. And one of my areas I look after is podiatry, and I'm also a podiatrist by background in my training.
Good morning, everybody. I'm Donna Welch, and I'm the Podiatry Operations Manager and Professional Lead for City Healthcare Partnership.
Morning, everybody. I'm Christy Francis. I'm Chief Operating Officer at City Healthcare Partnership.
Lovely, thank you. So I know that everybody will have read the paper that has been provided, so I'll just highlight a few key points before we move on to questions, if that's okay. So the aim of the discussion today is to outline the necessary changes within the podiatry service across Hull and the East Riding to ensure that people at highest risk of developing foot wounds that won't heal get the service they need as quickly as possible. We're seeing an increase in demand for podiatry services. We have an ageing population and more people with long-term conditions. And we've had to review the service specification and referral criteria for our podiatry service in order to help manage demand and decrease waiting times for those most at need. The changes bring the service in line with the vast majority of NHS podiatry services in England. The current caseload is comprised of around 12,000 adults, and it's estimated that approximately 50% will not meet the new criteria. Plans are in place to ensure that all are safely discharged following an individual face-to-face assessment and provision of self-care advice. The caseload of patients who will meet the criteria will still be in excess of 6,000. A self-referral system is being introduced, enabling people with changing needs to quickly access the service without delay, so without having to go via GP or other healthcare professionals. And all patients likely to be impacted by the changes will be written to in advance of their next appointment so that they're aware of the discussion which will take place. The changes have been discussed at the Pathway Review Group within the ICB. The referring professionals have been informed of the changes, so people are not being referred who don't meet the criteria into the service already. And a sample of patients who might be impacted have been asked for their views. Their valuable feedback is helping to shape the information and support provided to those who will be discharged. And the podiatry staff are also being supported to manage the changes, because we appreciate that this isn't an easy change to implement for anybody. So in conclusion, although it's regrettable that such changes have to be made, the revised eligibility criteria ensures that those with the greatest need and the highest risk feet will continue to receive a service. Self-referral will reduce delays for people accessing the service as their needs change, and all individuals will receive a face-to-face assessment and be given self-care advice. The changes bring our service in line with the majority of NHS podiatry services across the country. Thank you. Any questions?
Thank you very
Thank you.
much. Who would like to start us off? Diane? Councillor Stewart.
Thank you, Chair. I'm just very concerned about this. You know, there seems to be not a lot of forewarning for patients, and as a former nurse, it does concern me. Can you tell us how many qualified podiatrists there are in the East Riding, whether people can pay for them themselves or whether they access them through the health service? What are the numbers, please?
It's difficult to say the exact numbers because unfortunately not all podiatrists are registered with the Healthcare Professions Council or the Royal College of Podiatry. What I can assure you is that we're assessing everybody against a criteria that is it safe for them to be seen by an untrained professional. So in reality, they wouldn't need to see a qualified podiatrist. Nationally, there is a shortage of podiatrists, so we are struggling to recruit to any vacancies that we have. We have invested in employing apprentices and support workers to fill that gap, and it would be perfectly safe for some of these individuals to see what we call a foot health practitioner, a beautician or a family member to do their nails.
Oops. Thank you for that. Yes, I am still a bit worried, but I'm glad that you're investing and that you've foreseen the problem, which is part of the answer, of course. It's just that, you know, in my experience, people struggle to get a podiatrist anyway. So this is going to put much more pressure on the fewer podiatrists we have. But thank you.
Councillor Bibb.
Thank you, Chair. So from my understanding, there's going to be approximately 50% less people treated. And these people will have to either self-care or pay for treatment. I would imagine that will lead to less take-up because, you know, people won't be able to afford it or they won't be able to do it. So would that lead to more serious problems in the future? And how will you monitor this to make sure that people, you know, don't get more serious complications?
You're absolutely right. We saw during COVID that stopping low risk services then results in people having more complex needs. What I can say is at the moment, we're not delivering any quality of care for this caseload of patients in the sense that because they are so low to moderate risk, they're only probably receiving podiatry twice a year on the NHS now. So many are accessing private care in between anyway. What we need to make sure is that when somebody develops a foot emergency that they can get into NHS services within one working day, and we're struggling to accommodate that. When somebody is referred to podiatry, there is the potential for them to be on our caseload for 30, 40 years. So although we're receiving approximately 500 referrals every month, that's accumulative because we're not discharging that amount of people. So we're having a complete change of focus in that we're seeing the people who need us at that time rather than monitoring people. So hopefully it will mean that when they do have a problem, they have rapid access to us.
Okay. Councillor Walker first, I think.
Okay, thank you, Chair. Thank you. Yeah, this is certainly a significant change to the service, isn't it? And affecting many thousands of people. My question is really about the nature of engagement here. Notice that through the report there, the service has already fully implemented this, hasn't it? This is not a proposal. It's actually underway. Have I read that correctly?
We've implemented it for new referrals. So we applied the new contract to any new referrals from April. But obviously we've got an existing caseload that wouldn't meet the criteria. And to provide equity, because you do get people who say, my neighbour has their feet done, we've realised that we need to actually reassess everybody.
So again, I see that you, just on 1.5, bottom of page 9, there's quite a lot of information there about the impact assessment there, and related to the nature of consultation and engagement there. Within that, there are a lot of statistics in the final page of final sentences of page 9 and the top of page 10, where it's saying what impact would it have on your health if this service were no longer available. 304 people responded, but there's no breakdown of what they said. And that would colour the sort of consultation quite a lot, wouldn't it? And I wondered if within that you had contacted any other people apart from patients currently within the service, like OSC here today. So if you could set out how you talk to people about the changes, because it will affect 50%, won't it, of the people within that service. So it's pretty significant. So I'm interested if you could expand at all on how the people affected have responded, and the inclusive nature of who you've talked to before implementing the service.
So before we implemented this last year, we did a lot of consultations and discussions with the ICB regarding our contract. So there's a lot of work with Joe and colleagues across Hull and East Riding about all of our community contracts and what was going to be included in those contracts and what that would look like, so what we would be commissioned to deliver. And from that, it was some work we did looking at what was delivered nationally as well, so what should be included in our contract. So that's how that led into what we were contracted to deliver. So that's why we implemented our new criteria in April of all new referrals. And obviously, then we've had to do this engagement with our current caseload, because as much as we're using our new criteria on all our new referrals, as Donna said, when patients are referred to podiatry, historically they can be with us for such a long time. So we do need to now start looking at our current caseload and working with those patients and seeing if they do meet our new criteria. And so we've done this questionnaire with them, which are these statistics that are in here, and we've had a variety of different responses. Obviously, that if they didn't have this service, a lot of patients were concerned that who would then be available to look after their feet and cut their toenails. But they've not had that one-to-one discussion in a consultation face-to-face to say you are safe to do it yourself, you have the mobility, or your husband, wife, partner, carer. And they're not they're the conversations that will happen when they have that assessment. If they don't meet our criteria, that's when they'll have those discussions and provided with leaflets and advice on appropriate self-care, because we would only be discharging those patients that are safe, not medically needing to have their feet done by someone qualified. So that's where that will be picked up in those appointments.
Thank you. Can you describe what you would call medically needed? Because most of these people are very elderly and can't reach their feet, can they? Etc., etc. So medically needed is a sort of ambiguous phrase to me.
So they will be assessed whether it's safe for somebody who isn't qualified to do their feet. So fundamentally, is there a sufficient circulation that if they were to catch themselves, would it heal up afterwards? And we're basing our criteria on NICE guidance for the diabetic foot. So NG19 classifies somebody with 2 or more risks as high risk, and all of those will be kept and retained within the service. What probably will be the ones that are discharged, like you say, those who don't particularly have a medical risk but physically can't manage. We need to remember that sort of nail and skin care could generally be classed as social care rather than a medical need. And so, potentially it could be done by an untrained professional.
I see, yes. So let's hope everybody's got blunt scissors there.
Can I come in, Chair? Yeah, just wanted to add that as part of the discharge process for the existing patients, one of the things we're implementing, which is mentioned within the report, is what we call a patient-initiated follow-up, which is what NHS broadly is accepting widely. It's part of simplifying the access that should a person then deteriorate after the discharge happens, they don't have to jump through hoops, go to the GP to get a referral. They can directly contact the service to say, and they will be advised on what are the signs to look out for, etc. should that condition deteriorate. So that's a quick and easy access direct to the service. So we're simplifying it. Just wanted to make sure that that's there as a safety net and a reassurance for any patients who would be discharged. And just on Councillor Walker's point, the numbers mentioned here, we do have a detailed feedback of all the patients through the friends and family that we've collated. It's anonymous feedback, obviously, so we don't know who's referred to what comment, but as part of the discharge process, every patient will be offered a face-to-face appointment and review before they are discharged. So at that point, it's an opportunity to engage with them and find out if they've got any anxieties, and then advice on that self-management and self-follow-up should they need the service in the future.
That's reassuring. Thank you. Yeah, I think Jessica just wanted to come in, I think, didn't you, with is it a follow-up question? Yeah.
Thank you. Thanks, colleagues. And I completely understand the sentiment behind the report because you're managing demand and risk, etc. So coming from a collegiate space, but I suppose from a social care point of view, and you've mentioned it earlier, what support or what consultation or follow-up engagement are you planning to do with the private social care market? Because I'm just considering that we've got about 9,000 East Riding residents who either receive a domiciliary care package or are in a residential nursing placement. So if that lower level podiatry element is expected to be absorbed by carers, how are they going to be A, told that that's now part of their care and support regime, and B, supported? And I'm just conscious as well, because we're in that fee setting stages with our negotiations with care providers, and would that then mean that the local authority needs to anticipate that care providers are coming to us to say we're now doing extra tasks for Mrs. X, and therefore we need an increase in the fees? So I understand why you're doing it, but I suppose it would be remiss of me not to highlight the concerns from a social care perspective in relation to what impact that might have on the people who are already known to us Care Act wise, really.
Thank you, Jessica. I understand the concern, and I think it's a very good question as well. From a clinical perspective, as Dawn has already explained, we're not expecting at this stage that any nail care or podiatry specific tasks will need to be delivered by a domiciliary care provider in that sense. Obviously, basic nail care, if it's part of their package, then that's part of their package. We're not, and the type of patients we have, it's a mix of housebound and non-housebound patients, isn't it? So vast majority of these patients, our understanding on our caseload, do not already have that level of a care package requirement. So our assessment at this stage is certainly that it would not adversely impact on the domiciliary care market, but it is certainly something that we will continue to monitor. And we have the other parts of engagement with our adult social care anyway through our hospital discharge and admission avoidance. So if it is something that is actually coming up and becoming a theme, then that's certainly something that we can revisit at that point. Thank you.
Thank you. Next, we've got Councillor White.
Thank you, Chair. My question's about the moderate and low risk patients. They seem to sort of been grouped together, whereas obviously there would be a distinction between moderate and low. And when you said that patients have, some of them have 1 or 2 appointments a year, my question is, why have the moderate and the low all of a sudden they're then classed as discharged, and there wasn't this sort of scale going down where high risk are still looked after, moderate have had their appointments reduced, say to 1 a year, so you're still keeping an eye on those just in case, and then the low have been given the support to actually then care for their own feet? Thank you.
Oh, The low risk have been discharged probably 10 years ago. Unfortunately, some have crept back in because we're all health professionals who want to do right by patients. The moderate risk have had their appointments extended. I've worked in podiatry for 32 years, and the needs of our patients has shifted. We're seeing much more complex patients now that need extended appointment time. So initially we used to have a 20-minute appointment slot for virtually everybody. We now have hour appointment slots for people who need multiple dressings, complex vascular assessments and things like that. So what has actually evolved over the last 5 to 10 years is that the moderate risks have gradually had their appointments extended. They used to be seen every 8 weeks. Now they probably get seen, like I say, twice a year. But we still cannot, well, imagine my staff's point of view, motivation is very difficult when you don't feel like you're delivering any type of service to these individuals. And when we're thinking about the numbers of podiatrists, retention is an issue. So we want people to get job satisfaction and feel like actually they are delivering a reasonable service. So it might be helpful for me to explain to you what I class as a high risk patient. So anybody who has had a previous foot wound or a previous foot amputation would be retained. Anybody who's on renal replacement therapy, anybody who's immunosuppressed, anybody who has impalpable pulses, so an element of peripheral vascular disease would be retained. Anybody with extreme foot deformity, so it's putting increased pressure on an area that was then likely to develop into a foot wound. So what we're focusing on is that wound prevention and healing as opposed to general maintenance. I just thought that might be useful because thinking about your question, Jessica, most of those patients who are on those care packages probably would still meet our criteria. And it's up to 50% will be being discharged. Until we start reassessing people, we won't really know.
Thank you. Do you want to come back?
Yes,
Yeah.
please, Jen. And so one of the things I feel like I'm hearing is this is not due to money, this is due to staff. You haven't got the level of staff to be able to provide the service. So in that case, what are you actually doing to get more people to do this job?
So like I say, I spent a year with NHS England trying to tackle the podiatry workforce issue nationally. The universities are struggling to fill their places. It's not an attractive profession, unfortunately. And obviously since the NHS bursary was withdrawn, people have not wanted to study podiatry. What we have seen is the introduction of the apprenticeship programme, which makes it a little bit easier because staff members are actually getting paid and learning on the job whilst training, but that's a 3 to 4 year programme, so it's not an instant fix. We've looked at international recruitment, but very few countries actually, their qualification mirrors the UK, so to gain HCPC registration is quite difficult. We have successfully recruited a Spanish podiatrist who's doing really well and has been with us now for about 4 or 5 years. So we are looking at other options, but the reality is even in the private sector, there is reduced numbers. There's reduced numbers coming through. So we're working with careers interventions. We're trying to promote it, doing work experience. We're even looking at people with T levels to try and encourage them. And a lot of our support workers are being optimised to sort of incorporate sufficient skill mix to increase capacity. But you're right, it's not just about funding. Even if we have the money, we're really struggling to. And the other thing is that because the NHS workload has changed considerably, again, that's not that attractive because we're dealing with people at probably the end of their life. You're not really healing people, so a lot prefer private practice where they feel like they can make people more comfortable and see them as often as they like, flexibility and all that other. So we're sort of competing with private sector as well.
Thank you. Councillor Cantrell, next. Thank you.
Yeah, thank you. A lot of the questions have actually been asked. In my day job, I do visit lots and lots of elderly people, and looking at the 50% reduction in visits really for a podiatry appointment is actually quite a lot, because those people would have been referred initially because they needed support and help. And a lot of the people I've visited wouldn't dream of asking a family member to actually cut their toenails, for example. And it just feels like it's not properly being thought out. What happens if these people are so embarrassed to ask somebody? They'll end up getting infections. And I have been to people recently that have actually had that. So what is the support when this reduction happens? What is the support afterwards? How are these people that are having the service now? Is anybody actually going to chase them up and check that they are actually okay?
I could come in there. So thank you, Councillor Cantrell. So as we've explained previously, as part of the discharge process, you're absolutely right. There is a level of dependency that by default has been created because these people have been known to the service for many, many years. And as Donna has previously explained, some of these patients, we're only seeing them once a year or twice a year. So it's not as if we are there as frequently as they need their care. Because the criteria was so broad, these patients have been known to our caseload. But as part of the discharge process, we will be implementing a face-to-face assessment to provide them with the advice and guidance on self-care. We will do an assessment as well. Have they got the ways and means to be able to do that? We can signpost to other areas for self-care. We can give them advice and guidance on self-care. But most importantly, it's the patient-initiated follow-up. They can contact us afterwards if they feel that they are developing an infection. We will advise them on signs to look out for, and we will make it as simple as possible for people to access it back should they need it in the future. But we are not looking forward to that discharge process either, because as Donna has said, some of these patients would have been known to the service for many, many years, and it is a significant change for those patients, potentially anxiety provoking as well. Well, where do I go now? And like I say, our aim is to give them very good advice, detailed and support, and implement that patient initiated follow-up.
Thank you. Councillor Boynton.
Thank you. I can appreciate it's difficult. I'm well aware of other NHS services that have maybe had to change with budgetary pressures. Just going back to, I think Jess mentioned about the care homes and maybe picking up extra work there. I didn't quite understand, because I think, Donna, you mentioned that some of this will fall under adult health and social care, so a council run service. So I presume some discussions or contracting's already took place with portfolio holders, officers of the council, about what work will be picked up by the council, what work won't do.
So over the years, we've offered training and continue to offer training to anybody who wants it. Care homes, nursing homes, we attend care home forums and things to advise them on what to look out for and when they should be referring into us. My anticipation is that these patients will choose who they want to support them, and we will assist them in doing that by making suggestions. If they're not able to do it themselves, is there a family member, or do they have a carer, or some have beauticians that go and say paint their toenails, and are quite capable of supporting them in reducing the nails and the hard skin. So everybody will be individualized, and this is why we're insistent on reassessing everybody and having those conversations. We're not saying that this should be picked up by a social care package. We're happy to deliver training to support, but it's very similar to somebody who needs support with shaving or hair or other personal care, really. Like I say, if there's any risk, we will be retaining them within the service.
Thank you. Again, I do understand what you're saying. I appreciate it's difficult. I can just imagine when contracting happens with, our private services, they potentially will say now, well, actually, we are providing another service here, therefore we will charge higher fees. So I suppose the next question would be to portfolio holder and Jess there and say, has thought processes already took place? Have conversations took place? Have you got any concerns?
I think I'll hand over to Jess. I mean, certainly I haven't sat down and had long discussions about podiatry services. I'd rather sort of comment on building on some of the concerns that Councillor Cantrell's mentioned and Jess raised earlier. I think the very fact that Jess raised it was because we've highlighted concerns with this paper coming to scrutiny, which is exactly what it's all about. But first of all, my concern, and I've only been thinking this as we've been having this debate, first of all, a lot of the people that we're involved in care tend to be at that end where they need the care because they haven't got that family support, financial support to have all those services that they need. So there is a concern there that will these people still be getting that treatment? I think also in the care home situation, and it's a personal view because I mean my mother was in care for a long time, part of having somebody in care is you expect them to be looked after rather than you having to do it as in the family situation. So my mother had a podiatrist, went in, I got a bill once a month, but that was the only input I had. I just got a bill once a month and I paid it. How that came about, I do not know. And how it will go about in future, I do not know when people are in care settings. So I do have some concerns. I also have concerns that as an authority, our policy is to keep people in their homes longer, avoid residential care. So it's how we know that those people are also getting that treatment moving forward. So in answer to your question, no, I have not been heavily involved in discussions, but it has certainly sparked quite a few thoughts of discussions moving forward, and which is what scrutiny is all about at the end of the day. But thank you, and I don't know. Sorry, Jess, I'm sort of landing you in it without any discussion. Hopefully on this.
No, it's fine. And yes, similarly to our portfolio holder, I've not been actively involved in any conversations, but that's not to say we won't be as we move forward to kind of look case by case, not necessarily individual by individual, because that'd be more work than any agency needs. But I think if you're saying, I'm a little bit more assured the fact that you've said around there's going to be a discharge assessment and that the people who are most vulnerable, who are most likely to be in our care and support regimes, pathways will be maintained by the service. I think it'd be really good if we can take a piece of work away from this conversation, if that's okay, if you're in agreement around how we will engage with the provider market, what training might be set. So just so that I can anticipate that with the directorate leadership team. And then when we are going out to providers, like members have said, that we can bear the podiatry potential or lower level podiatry requirements in line with that. And it might be that as we move forward, when we do come to the individual fee settings for individual providers, if podiatry or low-level podiatry is now becoming a forefront of that conversation, we might then come to you as the experts to say, what does that need to look like, so that we're getting that value for money in terms of we're getting that evidence base around the fee setting. So it feels that there's a little bit extra engagement work that we might need as a partnership, but that would happen. So,
Councillor Owen.
Yeah, it's also to reflect on the fact we all know our sort of post-65 population is growing. It's almost an exponential rate over the next 10, 15 years. And it's really how that's taken into consideration. So, for the first time, I realised today that the length of time people might have podiatry treatment, it can be 20, 30, 40 years even. So those people are going to go on even longer now, and an increasing number, that population. I think part of those discussions, not for now, will be along those lines and how we cope with that as well. Thank you, Chair.
Andy, would you like to come in?
Yeah, thank you, Chair. Yes, on the back of what Jess was saying there, and a question I wanted to ask about, I get the pressures absolutely, we get the same in public health. In terms of the inequalities impact assessment and how it's differential in different groups, and I'm thinking isolated older people, maybe in poorer households, less disposable income, and also the impact upon falls prevention and where the assessment's been done. And I, again, happy to help out and link up different groups, but how are we identifying that risk and mitigating it?
So thank you, Andy, and thank you, Councillor Owen. So we have completed an equality and health inequality impact assessment on that, and you're absolutely right. The over 65s, which will be a big proportion of the caseload, and again, this is where that individualised assessment comes in as part of the discharge to provide them with the right support as part of that discharge package, and sadly, when people are known to that service, they are known for a longer term basis. So we will consider each individual patient by their merits, and absolutely happy to continue to engage. From a falls prevention perspective, we are an integrated service, so we do have referrals, so we don't have to ask the patient to go back. So if we identify a patient as a false risk, then there is a proactive management. So we deliver the falls prevention services ourselves, different levels. And again, patients can self-refer as well, should that happen. I think one thing we will definitely take away is I don't have the data handy at the minute to understand what proportion is the care home caseload who we might be discharging, and we will proactively engage with those care providers, continue to offer training, and we do have a care home advice and guidance line as well that people can contact. Obviously, that is more for medical purposes, but we can offer that as part of our discharge plan as well and continue to deliver the training. So, so those are the things that we will take away. Engagement with social care as well, should it impact on other agencies and it forms a dependency, then we'll obviously keep that dialogue going and ensure that we engage appropriately at that time.
Thanks. Thanks, Christy. Just a last point really from me. It's really good to hear that you're going to kind of work out what the care home percentage would be, just because I know that we're all mindful around the table that care providers are guided by the regulations within CQC. If one of their residents has a fall, that then will come into social care. So I can just see the interface with podiatry potentially falling, and then increased safeguarding activity, and then reduced CQC compliance, which we don't want either from a contracts and quality assurance point of view. So any ongoing engagement is really welcomed, really, I think, from a part of this. Thanks.
Just to reassure you that most care homes and nursing homes actually do have a private practitioner that goes in to do all the residents, and we work quite closely with them. They refer into us when they need be. So most of our caseload that's in nursing or residential home actually are already meeting that high risk status, because what tends to happen is they see the private one in between sometimes anyway. So we do know, and we do work very closely with those private providers in each of those care homes, and you're absolutely right. What generally happens is it's included in that fee for that individual. So, but we'll continue to do that.
Thank you. Next up, we just have Councillor Walker, and then I will ask my question if that's okay.
Thank you very much. Most of my other questions have already been asked, but I wanted to try and pin down that we are content that there is a mechanism in place to pick up those people who are discharged and whose circumstances change. They're not in residential care, and that they should be getting back in touch with the service, but they don't want to bother you, or similar. Is there a defined mechanism? I'm greatly encouraged by the communication just now with adult social care. So it would be good, I think, if this committee may be able to form a recommendation of support for that communication channel. We don't need to be in it, obviously, but to know that it's there and that both sides understand that there will be some people who still don't want to bother you in the service.
You get that with a lot of services, don't you, where patients don't want to bother the NHS, and then when they do it's when they're in crisis. And podiatry is will be access self-referral, but obviously we also accept referrals from anyone, any other providers. So social care, carers, relatives can make that referral on other people's behalf with consent. So we can get that referral in for them. And it's about when we're discharging them as well, that communication of we're here for you. It's not a bother. You do need to get in touch if you notice this and that. I know my family members don't like to bother NHS services. Certain people are that way, and it's just trying to encourage them to not get to that crisis point, and get to the point where if health needs have changed and their foot health has changed, then please do get in touch, and having those messages and that education, if it's from a carer going in and they notice there's an issue, supporting that patient and saying, well, can I get in touch on your behalf? Then yes, they'll be able to do that for them.
That's lovely. Just to labour the point, are adult social care and podiatry content that that mechanism is working and there's a communication channel to catch anybody later on and to see what the implications are for each other? Or do we need to establish it?
I think based on the conversations we've had today, we can certainly make the links to established forum, that we can link into, and we'll have conversations with Jess as to how to make that happen.
Super. Thank you very much. Thank you.
Thank you. We've got Councillor Bayram, Boynton, and then myself at the end. Anyone else want to come in? I don't know. No. Councillor Bayram.
I don't know how many people visit the little Chinese people who have come over and are setting up nail bars, and they do toenails as well and podiatry and everything. I didn't know if there was a check to make sure that they knew to look out for any illnesses that people may be showing in their feet, because they do seem to do a very good job. But there's a lot of like people a bit younger than me taking their mothers on and aunties and that along at the same time. I've seen them in there. So, you know, I think it's a good place for people to be picked up for illnesses if the people who are doing the feet know to look out for them.
Yeah.
Obviously, it's very difficult to regulate the private practice and private providers, and that's the reason why we're reassessing everybody, because if they don't need to see a HCPC registered podiatrist, then we wouldn't want to recommend anybody else, because we have no way of measuring their credibility or qualifications. But everybody being discharged obviously will be given the advice of when to contact. So it'll be them that will contact rather than these private providers. Any private podiatrist that's registered or known to our local branch has all been given the information on how to access our services, and we often well, there's many podiatrists that work across both sectors anyway, so we're quite hybrid, but we're linking in with the Royal College of Podiatrists to communicate things with those.
Thank you. Councillor Boynton, I think.
Thank you. Just thinking of recommendation, when reading the report and listening, it doesn't appear that there's necessarily been a change in NICE guidelines, or that the ICB have changed the contracts with yourselves. A lot of the changes really appear to be a staffing kind of issue in the main. Time and time again, when we've had dentistry here, podiatry, nursing, our own social workers, we hear time and time again about the bursaries, which we've heard again today. And I hope it's not seen as political at all, but could this be a recommendation to the national government to again really consider that bursary? Bear in mind, we hear it time and time again.
Rob?
Possibly things we've done in the past in that manner would be to write a letter to the relevant Secretary of State, and that's certainly something we could consider if the committee are minded. Again, it's the scope around this item is around this limited podiatry consultation relevant to the East Riding. But if members do feel that this is something they would like to do, we can do it.
Chair, I suppose the podiatry, you know, we're hearing about podiatry in the East Riding. We are hearing that the bursary has an effect on podiatry in the East Riding. So I'd suggest that it would fall in the scope, really.
Yeah, I'm happy with that. If I don't know what other members feel. Yes or no? Okay, we could have that as at the end then as a recommendation. Yeah.
We could say that because of our aging population, because we are one of the most aging populations in England, aren't we?
Okay, so has anyone, sorry? My turn, yeah. Anyone, oh, Councillor White.
Sorry, it was just something that sprung to mind. So I was just concerned about, we're talking about the staffing and that it's not a particularly popular area to get into. And this is maybe not, I don't know who could answer this, but then I've had one where people can't get jobs as nurses or they're struggling. And then you can't get staff in your particular area. So although we want the bursaries, why are we getting where we're taking on people to train to be a nurse who are then struggling to find jobs? And then I've got areas where it's not so popular. But if I'd have stopped so many people going down the nursing route, those people wanting to be in the NHS might have then picked you as the alternative. I'm not quite sure what my question is, but you're nodding like you think you might know where I'm going.
I'm actually really enjoying the conversations because anybody who wants to encourage anyone to go into podiatry is on in my corner. My time with NHS England, we identified that there actually probably needs to be a bit of a national campaign, and the Royal College of Podiatry is lobbying against Parliament. There was actually a speaker in the House of Commons who addressed the concerns about people in residential home about 6 months ago. So we do see that sometimes people want to make a career change. I've got a really exciting opportunity. I've gone out for an apprentice, so new year, new career. Anybody who's already got a degree could do an advanced short master's qualification that then would get them HCPC registration. And so we're looking at that. We're also looking at life after sports, after professional sports. There's been a couple of professional tennis players who've gone into podiatry, working with some football teams to try and encourage them. So this is all on a national level, which obviously it's really difficult, but for me, we really struggle in this area to recruit because we have no local education provider. So for me, the key is to get education providers who are willing to feed into the degree programme. So anybody, our local, we're working with some of the local colleges. North Lincolnshire campus is working with Sheffield Hallam to do assistant practitioner qualifications, which then would feed into a degree programme. So that's what we need. But like I said, this takes years to then evolve into a HCPC registered podiatrist. But yeah, we are looking at those options to try and encourage people to think of other opportunities. The reality is nobody knows what a podiatrist does, really. There's a Girl Guide badge that's been launched to try and encourage youngsters, because the research shows that actually parents are the biggest influence on what people become when they're grown up. So we're trying to get out there and to advertise the profession, but it's making slow ground.
Okay, yeah. Right, thank you. Yeah, I just wanted to ask, I mean, we've covered a lot already, and you've answered given us some great answers. So really, my question, part of it's already been asked, but I'm trying to picture when you come to have the interviews with these 50% of these people who are going to lose the service. And I'm just wondering what proportion of those residents, well, you might not know this, I don't know, but what proportion will have to pay for private treatment? and what support would be available for patients at the lower income threshold, simply because we hear all the time about how people are struggling. Obviously, we've heard about the winter fuel allowance situation, just very conscious of it's another pressure on some people who are really already struggling. So, and also the other question I wanted to ask is, when they say to you, well, where can we go now? Are you sort of recommending certain private practices, or are you not allowed to do that? And you just, the information is out there and they have to find it. Thank you.
I'm not comfortable recommending somebody who I don't know their qualifications. So, like I say, the assessment is that they don't particularly need to see a HCPC registered podiatrist, and HCPC registered podiatrist will cost a lot more money than somebody who's a foot health practitioner. So, I don't know whether you're aware, but the profession became a protected title. So, people who have done a correspondence course, for example, are not allowed to call themselves now a podiatrist or a chiropodist, but we actually we have employed a foot health practitioner to be one of our support workers, and we've really seen the value that they are actually really knowledgeable and able to monitor these lower risk patients. So our advice wouldn't be to see a private podiatrist, because that will cost them a lot more money, and actually if they need that, we would be retaining them. So our advice would be, if you can't manage yourself or you've got no family member who's willing and able, then our advice would be either to see a beautician or to see a foot health practitioner, because that cost is reduced. There are some charities, I know Age Concern used to have a podiatrist that used to, a foot health practitioner I think, that used to work out of there, that did it reduced fees. So there are some charities that are supporting, and like I say, we can link in with them and see if there's anybody that's available. But we didn't really want to give people a list, because we're actually saying that they don't need to see a podiatrist.
Yeah, I understand. Yeah. I think it's that dependency, isn't it, as well? You've got to get over that sort of feeling that you've had that service for such a long time and you've become dependent upon it. It's that transition, isn't it? And how that's managed. So I think we've heard some really good responses today. I just wondered, Simon, if you would, did you want to come in on anything, or before we wrap it up?
Very little, really. I think the point I think was made in the paper, and Joe mentioned it initially, is that this will bring the current service along similar lines to the vast majority of services provided nationally. So the East Riding, although it's not unique, it's one of a small number of services which still provides this level of care to the lower acuity patients. So that's one of the other aspirations of the integrated care system, is to have more consistency across its area. We obviously have to manage the risk, and I think colleagues are doing that in terms of that individual patient assessment. But again, I think for us, the priority needs to be making sure those people with the highest level of needs and the highest acuity, and I think colleagues mentioned some of the very complex patients, that they have the most appropriate and most prompt treatment. And that will mean, unfortunately, we have to prioritise our resources. But I think this is a necessary step forward. But I would welcome the support in terms of trying to encourage training, and particularly I think the point's been made about local training. One of the recent developments over the past 10 years was restarting nurse training in Scarborough, which I think has been really successful. And the more we can do local training working with education, the better. Thank
you, Simon. Rob, would you like to summarise for us then?
Thank you. So as it's consultation today and members had the opportunity to voice their concerns, I think the first thing you should be saying, should you wish, is that you thank officers for the engagement, and we endorse the proposals put forward.
Yep, absolutely. Yeah.
So secondly, I understand there's some discussion around the mechanism for referral for those discharged patients. After a period of time, and I'm not sure how long that would be, and I understand those discussions are going to be ongoing, if we could get an update back just to confirm that has been successfully implemented. I don't know what time period, if it's 9 months, a year, 6 months, what. I'll discuss with officers outside the meeting on that matter. And then finally, and that can just be through an email. We wouldn't expect a full item on that or anything like that. And then finally, from yourself, Councillor Boynton, about writing a letter to the relevant department to support the bursary scheme to support future workforce challenges.
Just thinking, could we add an amendment on bearing in mind what Simon said about local training as well? You know, we've had Hull York Medical School in the past and so on and so forth.
But if
Sorry, can I just query what you said, Rob, to start with about endorsing? What did you actually say? That we were endorsing what exactly?
so the proposal put forward, so this is a consultation report. So the colleagues from the ICB have brought this to us to update them on the current changes to the podiatry services. So this would be our opportunity to confirm.
So are
our
we
position on-
endorsing the new way of working, or are we just in? I'm confused as to whether I'm endorsing the new way of working, which I'm not sure that I would do until I'd seen the results to say whether I actually thought it was the best way forward, or am I endorsing the work? I'm a bit confused. Sorry.
You would be, if you were minded to, you would be endorsing the plan presented before you.
Yeah, I think the point of the meeting is that obviously we've had the report, we've scrutinised it, we've read everything, we've formed our questions, we've asked our questions, we've got the answers. And obviously, if you are satisfied with those answers, which if you're not, then really you need to challenge the answers, I suppose. But we've come to the point where we've asked the questions we wanted to, we've got the replies. So it's now a case of accepting the report as presented. Does that make sense, would you say?
Certainly, and I appreciate members may be hesitant because there is there is going to be a reduction in service. So you may want to include a line to say, with regret, to the impacted patients, but we appreciate the situation you're in, and we endorse the strategy.
Rob, Chair, could we also add that we want to encourage, as a committee, we want to encourage this newly established channel of reporting between adult social care and podiatry, because that should inform how the whole situation is unfolding. And it makes me a little more comfortable that this is underway now, isn't it? Because newly referred people are there. Sorry. Yeah.
So newly referred people, it's been underway since April, but obviously if they've never received the service, it's easier to tell them that they don't meet the criteria. We haven't started to discharge our current caseload yet. The plans are that we would start to assess everybody from February onwards, because we wanted to avoid obviously the Christmas period and winter pressures and things. Just to reassure, everybody will receive a treatment. I anticipate it's probably going to be 18 months, 2 years before we've got through everybody, bearing in mind they're only probably being seen once or twice a year as it is. So it's going to be a long process. We are actually going to be able to capture data on how many have been discharged as part of this process. So my anticipation is probably in 18 months we'd be able to give you that figure. And then we can also capture data, how many of that have then been re-referred. So hopefully that reassures you.
That's absolutely perfect for me. Thank you very much, because I can also see Rob writing this into the work programme for next time, because an update would be really useful later on. So that was the plan. These are the figures on how it's actually playing out. Thank you.
Yeah, I agree. I think it's really important, and I think the partnership that we've spoken about is crucial, actually. So we're relying on you guys to talk to each other, which I'm sure you're very capable of doing. So thank you for that. Anyone else?
Sorry, can
Simon?
I just make a really small, sorry to be pedantic, but I think one of the councillors used the word cut. There's no cut in service in terms of the volume of access to podiatry is the same. It's just in terms of the prioritisation who gets it. So we're not reducing taking any posts out or making the service any smaller. It's just how it's provided.
Okay, thank you. Right, well, I think that concludes. Sorry, conscious of time. So I would like to thank you all very much for your presentation, your answers. It's been really, really interesting. I'm much more confident now than I was before I came in the room, so that's a good thing. Thank you very much. I think we'll have a little bit of a break, if that's all right. Quick 10-minute break. Is that okay? Yeah. Just conscious of time, everyone. We could just start the meeting, please. Happy New Year. Yeah, I'm just conscious of the fact that we've got to be out of the room for 12:30 because there is another meeting. So I think we'll start with the next item on the agenda, which is pharmacies. So Simon, do you want to start off on this one for us? Thank you.
Yes, thank you. Well, I'll hand over to my colleague Hayley Patterson, who's the lead for primary care and pharmacies in the Integrated Care Board. So she's helpfully presented this report, which Hayley will cover some of the highlights. I think it's quite a detailed report, and again, the assumption is that colleagues will have had the chance to read that. So I think we weren't proposing to go through that in detail.
Thanks, Simon. Morning, everyone. Hayley Patterson, Programme Lead for Primary Care with a lead for pharmacy within the Humber and North Yorkshire Integrated Care Board. So, as Simon said, we've provided a pharmacy update, which shows that work continues with our medical care and community pharmacies working together to deliver both the local and national services. So the report provides an update on this in several areas. So I wasn't going to pick up anything, but there were some elements of the work plan that aren't included in the report that I was just going to pick up. So there was something about the current community pharmacy provision across East Riding. So as you can see from that slide, we've got 55 across the East Riding. It's really difficult to try and get them all onto one page. So the slide, which I'm sure will be shared at the end, has got the link which shows you where they are. And so I think there was some question about whether there were any areas that were isolated or significantly distanced from pharmacies. And that shouldn't say practices, but pharmacies, sorry. So there are pharmacies within the City of York, North Yorkshire and Hull. So for those patients who live on the border, there is that access in other areas if that's necessary. Next slide, please. Thank you. There was some query about whether there were any workforce challenges and whether they still were in existence. And I think with all sectors, as you've heard from the podiatrist service today and from some of our other services, that the workforce challenges do continue. We are made aware of these through the submission of failure to open notices from our pharmacists. So these are submitted when they are last minute short notice unable to open. So you can see from there, from the figures that we've had from April to July for last year and, the year before now, because we're in 25, aren't we, that the numbers are still high, but the number of pharmacies that are submitting those have reduced. They range from sort of a couple of hours to full days. We've got no one day that's affected more than others, so it's not necessarily just a Saturday morning. It can be any days of the week. And the main reason for those are that the locums are unavailable. We have a lot of anecdotal evidence from our pharmacies that locums sort of play pharmacies off against each other, so they'll kind of work for the highest bidder, and that often then leaves some pharmacies without a locum and unable to open for the day or for some hours. We are working with them to try and understand what their challenges are and how we can support those in that. It's difficult with their independent contractors, but we are trying to look at and see what we can do in terms of that. Because it's a last minute change, there is a process that they need to follow, and we try and ensure that all of our pharmacies are following that process. So they do need to let relevant stakeholders know that they need to close, so that the impact on the system or on the patients is as minimal as it possibly can be. So we let organisations like NHS 111 and the DOS know, so that they aren't then electronically referring patients to pharmacies that are open. So trying to sort of mitigate it that way. Next slide, please. In terms of quality provided by our pharmacies, we have got various ways of being able to do that. So there is a community pharmacy assessment framework, and that's an annual process that all of our pharmacies have to go through. It's a toolkit which assesses compliance and quality under their contractual framework. There are two parts to this. So there's a pre-visit screening questionnaire and a screening questionnaire, very simple, really high-level questions, just asking pharmacists sort of questions about processes and things like that. And from the responses to those questionnaires, we select about 5% of our pharmacists to go and do a contract monitoring visit. We have to go and visit our new owners. So when we've got some new owners on the patch, we need to go and visit those. So we'll go and talk to those. Sometimes it's based on the answers to those questions. And for others, if we've got any anecdotal sort of soft intelligence about concerns with any of those pharmacies. The pharmacy quality scheme is another assessment of quality, and that supports the delivery of the long-term plan. We didn't have any areas identified for 24-25 because there was a pause put in place when the general election was announced, and we're still waiting to see whether there will be any areas identified for 25-26. And then incidents and complaints are another area that we use to assess or look at quality. So we pick up as these arise, and these are all logged, so we can kind of look to see if there's a certain pattern with any of our contractors. If there are concerns, we do pick these up as part of the either as part of the CPAF, or we can go and do a standalone visit to pick those up and understand sort of what the issues are and whether there's any support that we can offer our pharmacies. So that's just in response to some of the queries that were picked up in the work plan.
Thank you very much. I think the first question we have is from Councillor Bibb.
Thank you, Chair. It's concerning the first slide. I just wondered if you could tell me what is considered isolated or a significant distance from a pharmacy, because I am concerned about residents in the more remote rural areas being left behind. Obviously, in some of these areas, the public transport's poor. There may be elderly and vulnerable people who don't have access for a car. So is there anything in place to mitigate this and make sure that people in these rural areas aren't left behind?
I think, so within our manual and within the regulations, it talks about a mile. And then I think, as we've recognised with the rural areas, it is difficult. And I think, we often don't have them within a mile. I think people kind of take that into account within those areas. And I know transport isn't great, but I think, but there isn't anything that kind of says, there's nothing kind of laid down that says when they need to be, where the pharmacies need to be.
Yeah, I would challenge them that I think there are people who are isolated in a significant distance from a pharmacy. For example, in Newton, which is in the East Coastal, Walton Coastal Ward, okay, it's around 10 miles to get to Bridlington or Driftfield, and a lot of the villages will be a minimum of 6 or 7 miles. So I do think there are quite a lot of people in the East Riding who I would consider to be isolated or a significant distance from a pharmacy.
Yeah, just to come in on that, on the map that you showed us, on the little, the bit with the sperm point, yeah, obviously it doesn't show the distance on the map, but where the two dots were, it looked like a long stretch, didn't it? Obviously we didn't get a tape measure out to measure it, but it did appear to us that when we discussed it in the pre-meeting, that was a long distance. But obviously, if you're looking at big towns, like Bidlington, Beverley, Goole, yeah, that's maybe not as much of a concern, but that stretch, and as you mentioned, that particular area did look quite sparse, I think.
Yeah, so there's, it's difficult, and I think it's useful to have the local knowledge that you've got. I think the only way we would know if patients did have access was if we sometimes get information from the councillors to say that there isn't that, but because they're independent contractors, it's not something that we can go out and say we need a pharmacy in. And I guess that's where some of the work with the local authority happens, in terms of the pharmacy needs assessment and assessments of whether there are any gaps in service, and I guess once that's in there, that then opens the door for those. But because with it being community pharmacy, we don't go out to kind of look for pharmacies. It's kind of that they're the vehicles for sort of identifying those gaps.
Andy, did you want to say anything?
I'll pass over to Shane for a second, but if I just put the context in terms of the health and care economics of it. So there's the need for services, for products, for advice. There's the supply and the right people to supply it with the right skills and the right stuff at the right time. And then there's the demand, and the demand isn't the same as the need. And getting that balance right between need, supply and demand in a rural area is very difficult when you don't actually employ all the staff and you don't open no buildings yourself. You have to encourage a market. At which point we have the pharmacy need assessment, which is an attempt to show the picture to encourage people in. But if I could, I'll pass over to Shane, who's been doing it for several years.
Thanks, Andy. So we're in the year where we revised the pharmaceutical needs assessment. So I'll be working closely with Hayley in the coming 6 months, and the the Health and Wellbeing Board will have a consultation process as part of the development of that document, probably starting in June and over the summer for an October completion. I think, as Hayley mentions, there's no sort of set definition of what is in, close to a pharmacy, but as part of that process over the years, we've tried to sort of do a travel time of 15 minutes as a sort of, and it's not nationally, agreed. It's kind of guidance, and it's kind of how it's developed, and most pharmaceutical needs assessments take that same approach to sort of measure how many of the population are inside that 15-minute travel time, and how obviously, in areas like ours, I've done this in North Yorkshire in a previous job as well. Obviously, there are quite chunks of population that will sadly fall out of that 15 minutes. I guess just to add to the map detail there as well, there obviously are practices that also still dispense that aren't part of that picture. So for those people who do live in some of those rural areas, you're able to access your prescribing medication at your general practice, as well as an actual community pharmacy. So when you put those on the map, actually, it does start to look a bit less sparse, but granted, there is still sparsity in our county.
Yeah, I didn't realise that. So that's a good point, that there may be some in GP practices as well. Yeah, thank you. Councillor Walker.
Thank you, Chair. Yeah, I was very interested in the move to be able to access the 7 clinical pathways and the registration process for that. And to access that service, I noticed that it's self-referral, and the table there on page 13 sets out the differences between electronic referral and self-referral and signposting there. But reading down that table, there seems to be a considerable advantage for digital referrals. And the other side of that coin is, the question, is there therefore a considerable disadvantage for those who are not digitally aware or digitally connected? Is there mitigation in place to help them, please?
I think it's maybe not clear in the report, but the digital referral is for the referring GP practice to do, rather than for the patient to do themselves. And I think the table was to show the advantages of being digitally referred by the general practice, rather than the patient referring themselves. I think there are just advantages in the fact that they can access more services than if the self-referral. Sorry, so yeah.
No, that's super. Electronic referral by the GP,
By the GP.
is the bit that I'd missed.
Yeah, sorry.
Perfect.
I'll add
Thank you
that
very
instead.
much.
Councillor Stewart.
Thank you, Chair. I think my query has partly been answered, but just for illustration, I do know a retired GP who delivered round Beverley. Now, Beverley is a big hub, but he used to work at the Manor Road practice, and when he retired, he delivered medicines round Beverley, and that's one extreme. The other extreme is I live in North Newbold. We have no shop now, but we used to have a shop, and they used to, the Southgate practice and the Market Wheaton practice used to both deliver to Bob's shop, so that people in the village could collect their medicines, because they were not always ready when they were at the GPs. So these are two very different ways of approaching things. And I just wonder if there is, if you know how, if you yourselves have knowledge of these kinds of arrangements that might go on, that there might be a pharmacy delivery service. I think, does Boots do something? I'm not sure.
Some of them do delivery service, but again, because it's not an NHS commission service, it's something that they would do themselves. And I know some pharmacies do a delivery service, but do charge for those. I think where there are those informal arrangements in place where, practices or pharmacies do deliver to Bob's shop is probably really great for those people that live in those rural communities. But it's those informal arrangements, I think, isn't it, that maybe it's conversations that have helped put those in place to support the community.
Thank you.
Okay. Yeah, I'd just like to ask a couple of questions, if that's okay. So my first question is, are there any pharmacies that persistently submit failure to open notices? That's the first question. And the second one is, what is the process for patients to receive a blood pressure check at their pharmacist? Because we were having a discussion about this. We weren't sure whether, if you got up one day and you were really thought your blood pressure might be high, could you just turn up at the pharmacy? Is there a machine that does it, you know, that you don't have to have assistance? Do you have to make an appointment? This kind of thing. So we
Yeah.
weren't really sure how that works. Thank you.
Sorry, what was the first question again? Sorry. Okay. I think that when we had a lot of the change of ownerships, we did have those pharmacies that did consistently submit those failure to open notices, and we did pick that up with the pharmacy. Sometimes they tell us themselves, which is much better than kind of them being dobbed in by GP practices or from patients. But we do work with those to ensure that they are fulfilling the process, and start with this kind of a management process through the pharmacy manual, and where pharmacies are consistently doing that and not abiding by the regulations and the terms of service, then we can start to work through a more kind of contractual route, if you like, so they get kind of a breach notice of doing those things where we can't do them again. We don't want to do that because it doesn't feel very supportive, so we do as much as possible try and work with them to make sure that they are working through that process and following it as they need to. As you can see, the numbers have reduced, the numbers of pharmacies doing them have reduced. Obviously the number is still the same. Some of them we are aware of that submit those failure to open notices where it's a particular pharmacy is because of workforce issues. And I know I've got one in the East Riding that is doing them because they're unable to get workforce later in the evening. And so that's a bit of a challenge that we're trying to work with them on, but it's really difficult to kind of, you know, that's why you need to be supportive, because it isn't not always necessarily their fault that they can't get somebody in to cover those later hours. But we you know, we are working with them and we are working to support them. In terms of the BP process, it is a walk-in service as well as a referral process. How the pharmacists deliver that service is entirely up to them. So some of them I know do have sort of set days or do have appointment times, and it'd be up to the pharmacy then to make sure that they advertise that, either whether that's within the pharmacy or whether it's on NHS Choices or their own website. So there are multiple ways that pharmacists can deliver their services. How they choose to do them is up to them really. So it might help them if they've got set times and days in terms of workforce. So you might then have a day where you've got a couple of pharmacists on, so you would have one pharmacist that might be doing those checks, or a healthcare assistant, because other people can, and a tech can do those. It's not just a community pharmacist. And I know they've updated some of the service specifications so that it's not reliant on the community pharmacy. They're, you know, community pharmacist, or is then be able to kind of continue to do other services well. Some support staff can do those for them. But I think sometimes where there are appointments or specific days and times, it is to help them manage the workload.
So just, oh, sorry, go on, Simon.
If you don't mind, may I just add, just in relation to the blood pressure, because you mentioned in terms of somebody feeling unwell. I think generally that the blood pressure measurement in pharmacies is part of a public health programme in terms of identifying people who may have high blood pressure, which is often a unsymptomatic and a silent health problem, which can be in most cases easily treated and can avoid more serious illness. I think we would want to encourage, if people felt symptomatic, so if they were ill and they thought it was maybe related to the blood pressure, to contact NHS 111. Pharmacies generally aren't a sort of a urgent care or emergency service. So if you had somebody who felt that, you know, that were really ill because of high blood pressure, that they should contact NHS 111, or if they're very severely ill, 999, or seek medical intervention. That isn't probably what the blood pressure tests within the pharmacy are there for.
Yeah, thank you for that. I was just conscious of how a person would know what a pharmacy is providing for what you're saying. It will be on their website. So because it's all quite new, isn't it? It's not what we're used to.
No.
So I'm just thinking about the comms side of it, or people tell me off for using that word, comms, so communication side of it, about how we get patients to understand what's going on. So
yeah, and I think a lot of our multiples are really good at kind of, like you said, doing you know, using social media, having posters and things up in the waiting rooms. And I think we're encouraging pharmacists and the staff to talk to patients as they're handing out medication, or whether it's leaflets or something within the bags. There is something about the you know, updating the NHS website and make their own website and making sure that the on there that kind of it says what service they are delivering. There are the links that we have shared with GP practices, and I think we have shared with Health Watch, I think, to be where pharmacies you find a pharmacy that's delivering a service near you. So that is available as well.
Thank you. Councillor Boynton, did you want to come in?
Thank you. It's just back to the failure to open notices, and you mentioned about agency at the very beginning and the possibilities of agencies kind of playing off pharmacies against each other, causing some of this notices to be put in place. In regards to kind of agency management, there's obviously framework agencies and off framework agencies, where framework there's an agreed price already set down, and therefore that agency is given the priority work. Is that in place with pharmacies to stop this kind of bartering of services, which then produces failure to open notices?
No, and I think it's many individuals when we've been talking to the pharmacies about the locums and reasons why they haven't turned up. And it is that literally sometimes it's sort of 5-10 minutes before they come, which is just, it's really not helpful when you're trying to provide a service to the public. But there isn't that, like you said, that kind of there's no set figure. I guess because so if people are desperate and want to open, they feel like they can command that figure and people will pay. But sometimes they can't and they don't want to get into that, which results in them putting in those notices, which is not good.
I found a nice easy fix for you. I mean, have a look at the framework agencies. If you're saying, right, we're only going to pay this set amount, and but we will give you priority work if you accept this set amount, then that would end all this. And I'm surprised that, I guess I know very little about pharmacies, I'll be honest, but I'm guessing the ICB pay pharmacy directly. So would it be something from the ICB to look at bringing in Sharpish, really?
It's a national contract, the pharmacy contract. So we commission services for them and pay for them to be delivered, but they're the local services. So it's a national contract. So it would be something that we would need to pick up through the national negotiations.
Sorry, Chair. Well, I think this national contract's not fit for purpose. Needs ripping up and sorting straight away. Really. So a recommendation would be straight about that, and I suppose I'm looking at Hayley to give us advice on the recommendation, really, and Simon.
I think in terms of the national contract, we would recognise that there are improvements within that could be made. I think in terms of the framework issue, generally, how part-time frameworks tend to work best is where there is a balance between supply and demand. Certainly what we've seen in other areas of healthcare is even where you have frameworks where that doesn't prevent people going off framework. And sometimes actually you will have individuals who will be prepared to work off framework at very high rates and not others. And we've seen that with doctors in hospitals. So I think there is work we can do in terms of redesigning the contract, but also the community pharmacies are for the most part private businesses, so the responsibility in terms of managing their workforce is theirs, although they have a contract in terms of it's not the ICB employing staff, or we're not paying directly to the locums for the most part. So I think it's something we need to take away from here, and we are working in terms of how we support pharmacies, but there probably isn't a quick fix within the current contractual framework.
One last go, and I'll be quiet, I promise. But I'm not understanding 100%, Simon, if I'm honest. So you've got your framework and off framework. So if you're paying framework at a set amount, but that's guaranteed work or likely work, that would drive down cost. Of course, there'll always be the off framework, but that would be very minimum amount of work and would drive people towards framework. I suppose as well with the ICB, while I understand you don't pay them direct, the ICB would set a contract out and say this is how much we're willing to pay to provide this service. So I'm guessing the ICB does have some say in funds there.
I think it might be a conversation we need to take outside of it. I think what I think most of the pharmacies aren't able to do in terms of a lot of their locum work is guarantee a set amount of work. So I think if you knew you were going to need a certain amount of locum or agency work 2 days a week for the next year, then you could contract with that. And the simplest thing actually would be to employ somebody to do that, or indeed employ somebody through an agency. I think where the use of agency staff becomes more expensive and complicated is where it's infrequent. And that's where the agencies tend to charge higher rates, and also where people will tend to pick and choose where they work. So that's where, even if you've got a framework, if you haven't got people on the framework who are prepared to work, you then have to either not have the service or look outside framework. So I think it is probably something we need to probably take outside the meeting, if that's because we could discuss this probably for the rest of the meeting, I suspect.
I'll add one more point. I mean, I'm not sure. Sometimes we can overcomplicate things, really. And you know, if you purely had off framework agencies, and we said to pharmacies, we'll only employ people on this, you know, on the framework, that would force it to go to framework to a set amount. I know what you're saying about set hours.
But you can't force people to go on the framework, can you? The framework would have to be voluntary. So where you've got an excess of capacity and you're able to secure people on the framework, then you could get people on the framework. But you can't force people on the framework. So people don't go on the framework, then you either have to not use, if you don't have anybody coming forward with staff on the framework, you have to accept you don't provide a service for a period, or you have to prepare to go off framework. So we don't want people where possible to not provide pharmacy. But again, I think it's probably maybe a discussion we need to take outside.
Last point, Chair, I promise. I mean, I disagree, because if you and then I will be quiet and we'll continue it outside. But if you go to framework and you only offer framework work, then the pharmacy would have to go to framework, otherwise they wouldn't get work, which then drives down the prices. I mean, I might be losing something here, but to me it seems a very easy fix.
But if they don't join the framework, then what do you do? But you can't force them to, so you would have to accept that sometimes your pharmacies will be closed.
In the short term, but in the long term, it would drive. We could go on a long time. I do apologise, Chair. We'll carry on outside.
Okay, Andy just wanted to come in on that one as well.
Just wonder if we could request a flow chart, block diagram. I'm learning quite a lot about the contractual obligations of pharmacies. Is it possible that you could start off that discussion with a briefing note to us of what the situation is, if there are any current proposals nationally to change it, and what that picture looks like, so we know what's being talked about between opposing systems? Would it be possible to provide such a thing for us, please?
Yeah, I think we can do. Yeah, do that.
Super. Thank you very much. Can I have my Andy? I think wanted to come in.
Andy.
If possible, I've got a small question about the 100 hours contracts. So we have the 100-hour pharmacies, 200 hours, and they're reducing down to 72.
Yeah.
And I think Simon's answered this one before, but around palliative care in rural areas and what we have in place to cover that drop from 100 to 72, is it a risk or not? In terms of having drugs available for people at the end of life.
Yeah, I mean, the out of hour services do have those, and we do have some pharmacies not necessarily in the rural areas, but within North Lincolnshire and North East Lincolnshire, that they have like an out of hours palliative care service. We've not had any concerns raised to us in terms of unavailability of that service. And I suppose if that did come through to us, we would work with the local areas to see if there's anything that we could put in place.
Thank you.
Councillor Steele.
Thank you, Chairman. Yes, I applaud the pharmacists providing these additional tests for patients coming in just to collect prescriptions. You know, opportunistic findings are very, very useful. My concern is what pressure is that putting onto the pharmacists, because I'm already aware of 2 pharmacies in particular where the queues are outside the door very, very often, just collecting prescriptions.
As a result of them providing other services, or
I think that's when they're not doing any tests because they're trying to get through and
so the addition of
get the prescriptions issued.
wanting to provide other services at the expense of kind of, I guess, not being able to provide, it feels what they should be providing now. It'd be useful to have the names of those pharmacies so we can look and explore if there's any support that they need. But it's not good, is it, when they're kind of queuing just to pick up prescriptions?
Yeah, I'd appreciate someone looking into that.
Okay,
Queuing outside the door, especially in the winter, people who are not very well because
No,
the queuing for
coming
prescriptions
to get a prescription
is not good.
Yeah, no.
I think Councillor Cousins just wants to come in on that one.
I'm very aware that pharmacists around the world tend to offer a lot more services than traditionally we've had here. I'm never quite sure whether this was an idea of providing better services to customers and residents, or whether it was a sticking plaster to make up for the fact that cuts had reduced our services elsewhere. But it does seem to impact on the availability of prescription services and, as Councillor Steele was saying, pharmacies providing what traditionally they have in the UK, which was giving out medicines. Certainly near me, waiting lists or the time waited for filling a prescription is up to 9 days. It did get worse, and it has certainly got worse since the epidemic and lockdown. But sometimes you're waiting 9 to 14 days for prescriptions.
That seems a rather shocking statistic, doesn't it? Yeah. Do you have information, data on that?
That's just from my local pharmacy, which happens to be in North Yorkshire, well, York, actually, Elvington, which is out of the doctor's surgery. But certainly in Pocklington, you do tend to see Facebook posts about failures to open, but also waiting times for filling in prescriptions from Boots. And other issues I know of around care homes that use local providers as well, of getting their monthly orders fulfilled, ready for changeover and things.
Yeah, it'd be useful to have a bit more, some more detail so we can look into this, because like Sam's just said, the 9 to 14 days seems quite a long time to wait for a prescription turnaround. I mean, I know sometimes the GP surgery says something and the pharmacy says, please don't set it ready in 2 days, because it won't. But so there's something about that, but that seems quite a long time, that 9 to 14 days. So it'd be useful to have, again, with the other one. Okay.
Yeah, we'll look into that, because I think typically you would expect 48 to 72 hours from ordering a prescription for routine. Now, obviously, there will be exceptions to that. As Hayley said, some cases they will need further conversation with the GP. In some cases, there are odd occasions where medicine's not available, and that will be a delay, and that is, a logistical problem. But certainly for routine prescriptions, we wouldn't expect that length of delay.
Councillor Owen?
Yeah. Particularly sort of wearing my health and wellbeing board hat on, because each year we go through the pharmaceutical needs assessment, which is a very specific exercise of demand and need and no more. And I thought it might get a bit confusing today, separating out the pharmaceutical needs assessment with what pharmacies actually do and provide. I think it goes back to Chairman's comment earlier about communications, because I am still unsure, despite all our knowledge and sitting around these tables, exactly what pharmacies can offer. There was a lot of promotion about pharmacy first, always go there before your GP. I still don't think nationally we've cracked that in letting people know having chatted with many pharmacists over the years, I don't think many people realise how well qualified they are and how long that period of qualification takes. You know, it's not just 18 months night classes, you know, it's a full time. And I think they fail to get that message across sometimes as to how professional they are and what they can do. So I just really want to reflect back on that. Is there a better way of promoting some of those services out with us all just worrying about them dispensing, you know, medicines? And then there's a confusion also, because I mean, I remember pre-COVID where you have a medical centre that has a pharmacy in there that's privately run and managed, competing with the GPs and some of the vaccinations they were giving. So we're actually fighting against each other in the same building as who could deliver a vaccination that case cheapest. So there's lots of anomalies in the system that need really looking at. But I think the main thing is getting the public out there to realise the range of services that pharmacists can offer, because I still don't think we've cracked that either nationally or locally. Thanks, Chair.
Thank you, Councillor Owen. Councillor Botal?
I've pretty much had my question answered now, so I'm going to just apologise for being late as well earlier, but I don't have anything to add. Thank you, Jonathan, Councillor Owen, for what you've just said as well.
Anyone else? Oh, Andy.
Thank you, Chair. If I can just, on the back of what Councillor Owen said, in terms of the role of pharmacies as a community asset, particularly community pharmacies, and the level of trust that's often built up over many years, and how they've developed their model, working with local authorities, working with NHS in terms of offering particularly health promotion initiatives about stuff in the summer, stuff in the winter, and certainly doing the vaccine parts during COVID and even this winter with flu. And there is often sometimes a tension between pharmacies and GPs over contracts and supply, and it's an ongoing management thing. But I think the move towards PCNs and involving pharmacies at a local level should bridge some of that gap. And if there are supply problems, and that sounds a long time for people waiting for their required medication. Sometimes it's a supply issue, and sometimes it's a very, very local supply issue. Or a workforce issue. But if you've got, I think, that working between local practices and local pharmacies, you'd find local ways around it. So I think there is a solution, and we shouldn't really be in that place of having 9 to 14-day waits. So I would hope that we wouldn't see that in the future. But if we do pick it up, and I would, if possible, if members could bring that to us, because that really would sit in terms of our P&A, in terms of a red flag. So we should now, with the present configuration, we shouldn't be seeing that.
And just to echo that, I think that I completely agree with Councillor Owen's point about the expertise of pharmacists. And although I do take the point in terms of the potential risks of increasing the pressure on pharmacies by having, as is in the table, the 7 additional conditions. I think most pharmacists, because of their training, are more than willing to actually do that and want to be seen as, you know, expert clinicians. They're not just, as we used to think of them, chemists who dole out prescriptions. So we do need to encourage that. And also that's another thing in terms of attracting pharmacists to the area. And again, so we don't need to rely on locums and whether they're on framework or not, is by making the role of pharmacy as attractive as possible. And one of the things that actually is quite attractive in working in rural areas is that bit about being that multidisciplinary practitioner in a local community. So so yeah, just echo what's been said.
Thank you. Councillor White.
Thank you, Chair. I just wanted to go back to what Councillor Owen said about how do we communicate locally what actually the services pharmacists offer. Whose responsibility is it to communicate that, and how are we actually going to do that? Because if we come out of this meeting, we've discussed that it needs to be done, but actually I need to know going forward, how are we going to do that and who's going to do that?
So because they're independent contractors, it is up to them to be able to update their website and update the Directory of Services so that it does reflect everything that they are delivering. It's not something that we can do on their behalf. It's up to them to be able to do that. And we can promote the services that pharmacists can register to deliver, but that's different from them actually doing the delivery, isn't it?
But in terms of the overall promotion of pharmacy as a concept, I think that the ICB and what I'd suggest we do, which I think we do to some extent anyway, but is the ICB in collaboration with the local authority through the Health and Wellbeing Board and linked to the pharmacy needs assessment, is to look at how we can most effectively promote that. What we have to be careful about is, as Hayley says, they're individual businesses. So what we aren't able to say is mandate what every pharmacy provides, or be really clear what every individual pharmacy does. But what we can do is help to promote the concept of pharmacy and pharmacy first, which we do already. But I think there is a bit about whether we can work collectively in terms of how we maximise the communication around that.
And I think there's something that we can do with our local pharmacy committee in terms of the roles and who does what, a bit like we've done for the GP practices, where you don't have to see the GP. There are a whole range of other, and again, you don't have to see the community pharmacist. You know, there are lots of other roles within there, and I think that's something we could pick up with the LPC to be able to promote that better, and work with our comms team as well to support that.
I think it's crucial because we come back to the same thing all the time when we sit on the Health and Wellbeing Board. We always bring this communication issue up. So I imagine a resident, you know, not knowing anything about this, because if I wasn't on this committee, I wouldn't know any of this. And that really is a concern, isn't it, from a member's perspective, because we represent the community, the people that elected us. So as you say, Councillor White, you want to go away and feel that you can now tell people what is happening. And we can do that, but we rely on something bigger than that in a way, don't we? So I think it's important that, as you say, the local authority and the ICB are really working together on this to get the communications right. Thank you. Anyone else? Have we all done? Oh, Councillor Stewart.
Yes, just to give you an indication of what pharmacists can and do. I recently was told by my very good it's the Ridings practice, that a GP would phone me. As it happened, it was a pharmacist, and she was fine. And having talked to me, she then said, "I will refer you to a GP. I think you need to see a GP." So you know, some practices are working very well, and I feel very fortunate to be registered with this exceptionally good practice. So pharmacists do a great deal, and I think they can be encouraged to do more if they have the time.
Yeah, and those types of, not those types because they're all community pharmacists, but some of them will now be embedded within the pharmacy, within the GP practice team, and that's where you'll get an appointment or a conversation with someone who is the best person to see. So there are, like you said, there are all those different roles out there, and community pharmacy or pharmacist employed by the practice is one of those roles.
Yes, she actually phoned me from home because she apologised that her baby might cry, which it did, but it worked very well. Yes, thank you.
Yes, Councillor Walker.
Thank you. Just talking about the embedded pharmacy offer within GP practices. Are they wholly employed by that practice, or are they an R's role? Or so they're responsible to the primary care network?
Yeah, it's employed by the PCN, so work across a range of practices within the PCN.
Right. Thank you very much.
Thank you. So I just got one other question, if that's okay. I just wondered what will happen to the walk-in community pharmacy consultation service after the 31st of March 25.
So this was the additional capacity that we put within community pharmacy. We have done for the last few winters to support the system, and it is a very time limited service. It always has been when it's been in. So the funding covers from the beginning of December until the end of March, when that will cease.
Okay, so what will happen after that? It will just end, or
it does just end. And the pharmacists are aware that it is a time limited, funding limited service.
Okay.
So we've just got the first month data, I think, came in this morning. So I just need to go and look at that to see. But the take up of that service is usually really good, and we have had discussions, you know, about how can we sort of maintain that locally. You know, not just for the winter period, but how can we support that? So there are ongoing discussions.
it would be good to get a further picture on that. So I don't know if we've got to the stage of recommendations now, Rob, or anyone want to chip in before we wrap it up? No,
No.
I think we're all done.
No, so I would first point, and I understand there was a conversation about the contractual arrangements for pharmacies. I think initially, if we do just request that as a brief note and maybe take it from there, yeah, as just if we can get that in writing, then it might help the committee just to decide what they'd like to do next about that. And then secondly, the only other point that I really got down was about the communication about pharmacies. And I understand it's difficult to detail exactly what every pharmacy is doing all the time through yourselves as the ICB or us as a local authority. But if there could be a greater focus on as a broader pharmacy offer communications through potentially through the Health and Wellbeing Board, if it could be raised there, I think that would be received well.
I think we could commit to attaching that to the P&A consultation and formalise. We'll promote the offer, what is, and then ask about how the population are finding that service. I think that will probably give you a firm action there, Rob. I think to tie it to.
Thank you. Well, I think that brings us to the conclusion. So thank you very much, everyone, for your contributions, and thank you all for coming today. I think we've just got, if members could just stay behind just for a few minutes after, we just got a little conversation to be had, but thank you all for coming.
Yeah, I'll try and be quick. So the only proposal I've got on the work programme is we have had a request for a to respond to a consultation on the closure of a GP surgery that's Walkergate, Beverley. So the proposal is that comes to our next meeting, so that'll be February. We've got dentistry on that agenda, but I'm sure that'll only take a couple minutes. But we'll put that one on first, so it will just be a 2-item agenda still.
Has Walkergate surgery not already announced its closing?
My understanding currently is it's done down to two days, so it's not doing Thursday and Friday. So it's gone down to 3 days. It's not doing Thursday and Friday, but it's the consultation is to close completely. I think Councillor Bertel's got.
Yeah, sorry. It's nice to be here, by the way, with health again. It came to me, it was really through Councillor Boynton's line of questioning. In all areas of the NHS, so dentistry, in pharmacy, it seems we rely on locum, we rely on these, because there is such a shortage of staff, they basically can charge what they want, and it's in a perpetual, when I was a governor of York Trust, that was a perpetual problem with the trust. And I just think it's a national issue. But I don't know whether, because I won't be here for your work programme setting agenda, I just wanted to bring it up that maybe it's something that you guys want to question or working group to discuss, because ultimately the NHS cannot continue doing what it's doing. It's only going to get worse. It's basically privatising all your staff. And I don't know how you go about it, but I think it's worth a discussion and some heads being knocked together about actually we see this as a problem and we want the NHS to do something about it, or whether we write a letter to West Street and whatever it may be. I think it's a massive topic that comes up every time there's a different service in for health. It always seems to be a problem.
Andy?
I could suggest regarding workforce planning with the ICB and what are the workforce plans, what are the pressure areas, and what they're doing about them as an update.
Will we be able to fit that in, Rob?
Yeah, so I'll we because we've had to cancel this afternoon's workshop to delay it till next month. There's certainly time to put it in. So fortunately we've got so many meetings and there aren't actually that many items submitted compared to what we get for other committees. So there is capacity to add them in. So we'll certainly do that. I think just from memory we did health. An adult social care workforce planning item. It wasn't this year work programme, but it might have been the last one. So it might be timely to look at that again. It was quite focused on ASC, adult social care. So it, from a
Yeah, I think
ICB
it
perspective.
was adult social care, but this would be ICB's
Yeah,
finger in the
yeah.
pie instead, wouldn't it? Because although they're the paymaster, it would be interesting to know what the plan was, so we would know what vacancies and pressures they're trying to address. Because across the NHS, that's not clear, is it?
There seems to be no national desire to solve it. You know, maybe Wes Streeting will give everyone a massive pay rise and they'll all come back from locum into the actual service, but somehow I doubt it. But you never know. So it's kind of, I just think bringing it up, having the ICB here, challenge them on overall workforce issues might just highlight it to them to then start putting it into strategy. I don't know.
I would be happy to invite West Street in, however, I'm not sure. The only thing I would comment is that we may be able to get the ICB's long-term plan, but a lot of it, I imagine, will be dictated by national issues. So it might be limited to how much we can recommend in terms of an outcome, but we can certainly ask the question and get a picture for what the next 5, 10, 20 years might look like.
Yes, I had a bit of an experience with somebody answering the phone who I didn't expect to answer the phone. I rang 999 because Charlie was so ill and he looked dreadful, more dreadful than normal. But it was a paramedic who answered the phone and somebody I wasn't expecting at all. So we ended up having a conversation about what was wrong with him and everything. Then he spoke to Charlie and then we decided that it was fine. He just had vertigo. But that was good. Oh, right. Sorry. But it was really good that somebody like that knew all his stuff and could really help him. So we didn't have to have ambulance. Everything was fine.
Well, we just come to the forward plan item, but we don't have any updates for that. So that's the end of the agenda, Chair.
Thank you. Thank you, everyone. So just